So welcome everyone. We're glad to have you joining us for the Professional Standards Committee. So I'm glad to have you all with us. So to begin, I want to begin first and foremost by acknowledging that we are here together and that I am speaking from Mi'kma'ki, and indeed the Nova Scotia College of Social Workers is in Mi'kma'ki, which is the ancestral and unceded territory of the Mi'kmaq, whose inherent rights were recognized in the peace and friendship treaties that were signed from 1725 to 1779. This series of treaties did not surrender Indigenous land, resources, or sovereignty to the British Empire, but instead established rules for an ongoing relationship between nations. The treaties were later reaffirmed by Canada in Section 35 of the Constitution Act 1982 and remain active to this day. The Nova Scotia College of Social Workers joins our members and our communities in the necessary labor of reconciliation, and we are grateful to live and work together as treaty people in Mi'kma'ki. Please think of the lands, territories, and Indigenous peoples who lived and continue to live within these lands, and how each of us individually and as a collective body of social workers can hold ourselves accountable to reconciliation with Indigenous peoples here and across Turtle Island. We are all treaty peoples. Ulaliu, thank you all. I want to take this moment to thank all of the volunteers of the Medical Assistance in Dying Working Group subcommittee of the Professional Standards Committee for all of their time and hard work in developing these standards. I want to especially thank Haley McIntosh and Cheryl Tschupruk, who are both going to be leading us in today's session, which is session 1. So I'm going to stop share now, and I'm going to invite Haley and Cheryl to both begin speaking, and they are going to lead us in some of this work. This is, again, session 1 of a 3-part session that we are offering. So the first is simply a review of the laws and a review of the what we should do. But there's 2 additional sessions looking at the ethical implications of this work and the social justice and legal implications. So we hope you will join us again next week and the following week for the other 2 sessions. But with that, I am going to be quiet, and I believe that Haley and Cheryl are going to begin.
Hi everyone, my name is Haley McIntosh. I am a social worker here at the Nova Scotia Health. I want to start off by saying that I'm so appreciative that you're here, and also that I don't represent the Nova Scotia Health nor their policies. I am just working within what we find as social workers. And if you do have any questions about guidelines or policies within Nova Scotia Health, I would suggest that you do go and speak to your direct supervisor, who can then escalate it if necessary. But I am here just to talk briefly with Cheryl about medical assistance in dying and the new guidelines that have taken effect, as well as revisiting the guidelines that are still very pertinent within our scope of practice. So today's agenda for us will be, oh, there we go. Of course, part of my screen is not visible. So the goals of today's presentation is to review medical assistance in dying and the laws surrounding access to it, as well as reviewing MAiD and Nova Scotia, and particularly through Nova Scotia Health. I'll come back on after Cheryl's spoken about that, and we'll talk about reviewing the guidelines pertaining to the scope of practice for social workers. And then we'll finish off with a little Q&A if there's any questions with regards to what's come up through there. So if you want to, just throw it in the chat and we can address it at the end, or if you just kind of want to raise your hand at the end as well, we'll do our best to answer all the questions. So medical assistance in dying is noted in section 241.1 of the Criminal Code of Canada. It refers to the administering by a medical professional or nurse practitioner of a substance to a person that causes their death. The prescribing or providing medical practitioner or nurse practitioner of a substance to a person at their request, so they may self-administer the substance and in doing so cause their own death. So we just have a link there as well, and this will be available to people on request, which brings up the Criminal Code of Justice on justice.gc.ca, and you can review it more in depth. There's quite a large section devoted to that as well. So a person receiving MAiD may only receive MAiD if they meet the following criteria right now as it stands within 2021. They are 18 years and older and have decision-making capacity with respect to their health. They're eligible for a government-funded healthcare service or would be eligible, but for an applicable minimum period of residency or waiting period. They make a voluntary request for MAiD that is not a result of external pressure, and we'll get to that in the guidelines. They give informed consent to receive MAiD after being informed of the means that are available to relieve their suffering, including palliative care. And of course, I can't see that, sorry. And they have a grievous and irremediable, that's probably not how you say that, medical condition, which is defined as having a serious and incurable illness, disease, or disability, excluding mental health currently, be in an advanced state of an irreversible decline and incapability, and that illness, disease, or disability or state of decline causes enduring and intolerable physical or psychological suffering that cannot be alleviated under the conditions the person considers acceptable. So in order to access MAiD, they do really need to be aware of all the palliative and treatment options as well. It can't be offered as the only solution to their situation. They have to be given multiple trajectories and timelines and interventions as well. Yeah, so according to the government of Canada, Canadians whose only medical condition is mental illness and who otherwise meet all eligibility criteria will not be eligible for MAiD until March 17th, 2023. So this includes conditions that are primarily within the domain of psychiatry, such as depression and personality disorders. It does not include neurocognitive or neurodevelopmental disorders or other conditions that might affect cognitive abilities. So the summary of the changes, which is hopefully everybody can see that in their screen. So while the original legislation was in 2016 and it restricted access to MAiD to those whose natural death was reasonably foreseeable, the eligible criteria was expanded in 2021. Although these criteria, those related to mental illness, are not yet in effect. So in 2016, you had to be, I think it was within 3 months of a palliative state. And now it's a little bit more open and foreseeable. So I'm not entirely sure. And Cheryl can speak more about that, about how long. So if we just kind of look down through the changes that were made, sorry, I'm just trying to see this with my glasses, which is very embarrassing. There's a new strengthening of safeguards for eligible people, as well as a final consent that has to be provided. So what they're trying to do is give more access and more reasonable access to individuals requesting the service as well. Yeah, so we'll just move on to that, the next one. And I think it's now Cheryl's going to be taken over from
Yeah, so maybe what I can do is just touch on this a little bit, and then I'll move into the Nova Scotia specifics. So
perfect.
hi everyone, and I want to thank you as well for joining. My name is Cheryl Tschupruk, and I am a registered social worker, have been since 2001. So it's been a little while. I'm currently the interim director for the Medical Assistance in Dying program here with Nova Scotia Health, and I'm also the director of the Palliative Care Network. So just to kind of review some of the changes a little bit further. So originally, as Haley mentioned, people needed to have the grievous and irremediable condition, and the death had to be reasonably foreseeable. And there was no specific timeline attached to that. I don't know what that means. Can you see that? There was no specific timeline attached to that, but reasonably foreseeable was really kind of within the purview of the assessor to review with the patient and based on their medical condition and what was likely to happen. The non-foreseeable death category is new, and really it speaks to people who are in a current state of suffering. And so their death may not be reasonably foreseeable, but they are enduring suffering and meet the other criteria. So the final consent, the big change there is that previously a person had to consent to MAiD immediately before the procedure. And this change is actually referred to as Audrey's Amendment, based on an individual from Nova Scotia who was advocating for this change. And basically what her concern was is that she felt she needed to schedule her MAiD procedure well before she actually wanted to have it, because she was concerned she would lose capacity and not be able to consent in that final moment. So this allows for people to sign a waiver of final consent, and it's only eligible for people who have a reasonably foreseeable death. And so they can provide consent so that in the moment before MAiD, if they do not have capacity, they have pre-consented to receive MAiD. And there's a specific form that needs to be completed, and there's all kinds of safeguards that are part of that as well. So MAiD in Nova Scotia, I've included some statistics because I think it's important to share just sort of what this looks like right now in our province. And so you can see that there's been quite a bit of growth since 2016. And I've included our 2021 statistics here, and these are actually only accurate until end of September. So I think at this point we're reaching close to 420 referrals. And so there's been a lot of growth in the last few years for sure. Some information about the types of diagnoses that we see. So by far, cancer diagnosis is the main category of referrals, but you can see that there are others as well. And this is Nova Scotia data. Where does MAiD take place? It can take place pretty much anywhere. This data is actually federal data. It's not Nova Scotia specific, although our numbers are very similar. So primarily in hospital settings. And secondly, this should be in order and it's not, but secondly would be in private residences. So there are a lot of procedures that take place in the home, palliative care units and residential care, meaning long-term care, or some other type of assisted living. And then other, like I said, I know of MAiD procedures that have taken place in parks, in other local or public places. So that gives you a sense of where MAiD takes place. And then I've also included our monthly referrals because I think it helps to show the growth that's taken place over the last several years. And this goes from 2018 to 2021. So a little bit about the Nova Scotia Health MAiD and Access Resource Team. So this used to be called the MAiD team, the MAiD coordination office. We've had a few different iterations, and this past year we changed our name to the MAiD Access and Resource Team, really to reflect what our team provides. And I've listed our team members here and added some photos. Mine's a little bit dated. And we also have a nurse practitioner position that is going to be starting with us soon. So this is a new addition to our team, and this individual will be helping with some of the assessments and procedures, mainly in areas where we're having gaps, identifying local providers to support the work. But we'll also be doing a lot of education and practice support. So really trying to support providers who are involved in MAiD, supporting debriefings and that type of thing. And then we also have a clerk role because there's a lot of administrative work that goes along with this program. And so really wanting to make sure that we get that right. Our hope is to add a social worker to our team because we know that patients and their families have a lot of psychosocial needs related to MAiD. And as much as we would love for all of our social workers to support those patients and be involved in any way they can, I do think that there is a need for some more support and more individualized support when that's not available. But this person could also potentially help with some brief support and peer support groups and that type of thing. So stay tuned because I'm hoping by April we'll know if that position can be added to our team. So what we do, our team does not, so Dr. Gord Lubitz is our medical lead, and he is involved in MAiD assessments and procedures, but the rest of the team, we're really here to support access. So that is really Nova Scotia Health's role in MAiD, is to facilitate access to this service for people who want to explore this option. So we help to coordinate and streamline the process from the point of referral. And that can include providing information to people, and that can be patients, families, healthcare providers, members of the public, anyone who's calling to ask about what MAiD looks like and how to get a referral, that type of thing. Completing an intake assessment. So Nicole Finney, our MAiD nurse navigator, completes an intake assessment for every patient that's referred, unless for some reason it's not required. And during that process, she's asking the patient and their family members about, their individual needs and preferences and anything that we need to know that can help support the process. So really, it's not just about getting an assessment and having a procedure. It's really trying to understand their goals, their wishes, how would they like this to go? What can we do to support them while they're waiting? And then connecting patients with providers. So we have a team of healthcare providers, so physicians and nurse practitioners from across the province who participate in MAiD, and they do this voluntarily. So it's not that they don't get paid to do it, but that they're doing it in addition to their existing roles. So there's a lot of support that is needed to help this process go smoothly. And then supporting eligible patients who choose a medically assisted death to have access when and in the location they choose. So like I mentioned before, MAiD can happen in many different settings. And so each of those settings have specific requirements and special needs around helping to establish IV access, helping to make sure that there's a bed available if someone wishes to have MAiD in a hospital setting. And really, again, just trying to make sure that the process goes as smoothly as possible for people. So although MAiD can take place in any setting, really, we do have a policy and procedure, two different documents, policies and procedures, to help provide clarity on how MAiD can be discussed, how it can be provided within the context of the legislation. And so we actually have a policy and procedure document that's ready to be approved to replace the old policy. And I think people who have seen the old policy will find this one much more detailed, especially the procedure piece. So the procedures document. The policy is short, but the procedures document really kind of walks through step by step what's involved and whose role it is to do which pieces. So these documents, though, they do emphasize that healthcare providers always need to refer to their college guidelines or standards for specific details on how they can be involved. And I did include here our website. So our website has lots of information on it as well. And Also wanted to make sure everyone's aware that we have recently created a family and patient guide, our patient family guide, and it's available on our website for downloading, but we do have hard copies that people can order. So if anyone is interested in having some of these hard copies and you don't have them yet, you can email our office, and I probably should alert them that they might get a few extra emails in the next few days, but and I've just kind of included the contents here so you can have a sense of what's included in this document. It's pretty long, but I think it gives a lot of really good information about how to access MAiD and some of the frequently asked questions that we receive. So I am going to hand it back over to Haley.
Hello, everyone again. So I'm going to start talking about the guidelines as it pertains to the Nova Scotia College of Social Workers and the majority of people accessing it kind of within Nova Scotia Health as well. Again, it's important to recognize that while we might have guidelines, it's very important that not everybody knows those as well. So I'm glad that we're getting this opportunity to talk about it, because I can talk more about specific situations where I was kind of asked to go outside of my scope of practice with regards to MAiD. So again, just remembering that not everybody has access to this, so it might be a boundary that you have to discuss with. But first and foremost, MAiD allows for conscientious objection. So if you as a social worker feel that it conflicts with your moral beliefs to support an individual accessing MAiD, you can decline to participate in in aspects of care connected to MAiD. If you do choose to not to participate on these grounds, you do have to ensure that there's another social worker there available for support. And you also have to kind of provide an accurate transfer of accountability, as well as speak to the patient in generalized terms as to why you aren't providing care. But in no way, shape, or form should you be projecting your beliefs about access to MAiD on them as you are doing this transfer. So that's within our standards of practice. So for those who feel that they are capable to participate in individuals accessing MAiD and supporting them, the guidelines for that are, there we go. It's important that we do remain in our scope of practice. So it's important to know that only a nurse practitioner or a physician may administer or prescribe the substance that caused death. That's pretty easy. We can't prescribe any medication, so that kind of takes us out of the realm, out of our scope of practice, and there's a lot of great safety guidelines that will not allow us to access that. Now, while we may assist the nurse practitioner, the MD in providing support to the person, we cannot provide the substance that causes death. So sometimes we are asked to be in the room, and I have been, but I could not participate in anything other than potentially helping an individual readjust or become more comfortable, but nothing to do with the actual administration of the substance itself. As a social worker, we are not permitted to counsel or suggest or advise a person to choose MAiD. In that we are not able to say that this is a treatment option, and we are also not able to encourage an individual to seek it as a treatment option. It must be voluntarily brought up by the individual. However, if you feel that a patient is not being given all of their treatment options, it is your responsibility to go to your supervisor or your director or whomever it might be and tell them that you feel that that option has not been made available to them. So if you feel that a doctor is only offering them palliative resources or potentially pain management resources, and you feel this person is eligible for MAiD based on conversations that you've had for them, but they just don't know the language to access it, you specifically are not able to speak to them about MAiD. However, you can bring it up to the medical team that this perhaps should be an option that is brought forward to them. And that is done through the nurse practitioner or the physician. So you cannot bring it up to the patient themselves. Oh, I apologize. So social workers can provide psychosocial support and or therapeutic counseling to the person who has requested MAiD, as well as their family members. It's particularly challenging within an inpatient unit because you do have such a limited amount of time. However, there are some resources that are available outside of the hospital. To my knowledge, I believe the Hospice Society has a grief counseling group, but I also acknowledge that there are very, very limited supports for individuals whose family or loved ones or partners have access to MAiD. So I do think that is an area of opportunity for us as a college, as well as within the Nova Scotia Health as well. So we are able to support a person who voluntarily expresses interest or expresses interest on behalf of someone in MAiD to access information. So providing brochures, making suggestions that they speak to their nurse practitioner or NP or MD. It's also part of our practice that if a patient is asking for it and advocating, that they are able to have that conversation. So another personal example would be that I did have a patient within a nursing home ask to access it, and I was sent in to do a suicide assessment, as well as convince a person not to access that service. I will say this was very, very new. It was at the beginning of 2016 while this was all rolling out. And so I had to very clearly explain that my boundary was to advocate for a person if they wish to access the service, or at least to have as much information as possible so that they could create an informed decision as opposed to being just told no. So again, within our scope of practice, we provide that person with the contact information for the Nova Scotia MAiD Access and Resource Team, or we can call them ourselves to obtain more information of MAiD. And again, we do need to escalate if we feel that this person is not being given every opportunity to access MAiD or are being swayed in a position because of another person's moral beliefs. So we are within our scope of practice, we are able to escalate to the supervisor if we are unsure of our role in relation to MAiD or concerned a patient is not being provided with appropriate access to MAiD. Again, just to make it really, really clear, a social worker cannot counsel or suggest or advise an individual whether or not MAiD is appropriate for a person to decide. And I'm sure all social workers are capable of doing that because we talk about people's goals and values and how that moves them towards their decisions, and we try not to insert our own personal beliefs and judgments as well in that. So I don't think that's truly a very difficult job for social workers, but we are also unable to administer or provide the substances that cause death. Okay. And so we have some references and resources here that was used to create the guidelines and criteria. And so we looked at both federal and provincial resources, as well as what other Canadian societies of social work had looked at as well. So that's pretty much all she wrote for that. I'm just very keenly aware that I just got recorded saying that. But we will open up the floor for any questions, keeping in mind as well, though, that this is not the time to discuss ethical dilemmas, because we will actually have an ethicist joining us for our next meeting, who I know is superb at explaining very good points of view. So I would ask that you just leave those questions until then. Thank you.
So yes, thank you so much, both of you, for giving an overview of the guidelines that we have passed that are now on our website, so that and this video will also be available for you to be able to access, as well as the other videos, just so that you're aware of some of the nuances, because it's one thing to think about it in abstract and it's another thing to be working with a family. That being said, we do have a little bit of time for some questions, mostly in terms of clarification of guidelines. There's some interesting conversation in the chat about this concept of funeral homes opening up spaces to be used for medical assistants in dying who don't want to complete it in their hospital or in their home. Cheryl mentioned other, which was a little light category, but I wonder how much that has to do with people not knowing or making assumptions about where it can be delivered. So, you know, maybe someone wants to be in a park, was what Cheryl mentioned, or near the ocean or something like that. And that could be truly transformative, I would imagine. So those are things that, like, it's good for us to, at the very least, even know and understand the law so that we can provide more clarity. Obviously, this is a new law that's in process and transition. Okay, so here is a question. I noticed the number of referrals for MAiD is roughly double the completed numbers. Can you speak to what factors contribute to this?
Sure, I can do that. So the numbers are pretty consistently. So one thing I'll mention is that on the Medical Assistance in Dying website, there is a tab called reporting. And when you click on that, you can actually see data from 2016 until now. And we keep that pretty up to date. So the most recent update was at the end of September. So we try to update it monthly. But on that sheet, there's a breakdown of completed MAiD procedures. And then there's a category, I'm looking at it now, which is why I'm looking up, but there's a category for natural death before MAiD, which means that the person had completed assessments, but hadn't scheduled their procedure and died naturally before the procedure took place. So that would be one reason why MAiD was not completed. Died before MAiD is another category, and that one would mean that they were waiting for assessments or waiting for something. It's a pretty small number because we really try to prioritize, you know, when someone is ready to move forward with scheduling their procedure, those are prioritized. So it's rare, but it does happen. The other one could be that the patient lost capacity. So in the past, that would have been a higher number because they need to have capacity in the moment. This past year, if you see numbers under that category, it would mean that they likely lost capacity before they could sign their waiver of final consent. Does not meet criteria is another reason why someone wouldn't be eligible. So we received the referral, they had an assessment, but they didn't meet the criteria. And then we do have a lot of people who receive their 2 assessments and change their mind. So they cancel the referral or are happy to have the assessments and just wait to see how things go and then never move forward with scheduling a procedure. So those are some of the different reasons why the number, I don't think will ever be the same as the number of referrals. I hope that answers the question.
Thank you so much. Another question is, what have you noticed about social workers running into difficulties with MAiD issues, which is certainly a good broad question that you guys can certainly begin to address, but that probably the next 2 sessions will also flesh out into greater detail.
I think I can talk to that a little bit because I do work on a geriatric unit and we've had quite a few referrals for MAiD as a person kind of goes along their illness trajectory. Personally, the challenges that I have is kind of the lack of training with regards to how to appropriately support a family that is consenting versus dissenting as well. As well as supporting a patient who was turned down for MAiD. So they didn't meet the criteria at the time, but they would be reassessed. And in fairness to the doctors, they did a very comprehensive assessment, and this person, you know, had goals that were unfortunately long-term, but also wanted to access MAiD at the same time. So it was very challenging for that doctor to make a call for that person. So for me, my personal ones have been supporting an individual after they've been denied or been told that they're there's a few things that need to get worked out before we do look at MAiD as an option, as well as working within a family. So I have had patients that very clearly can articulate what they want, and have had family members that are completely on board and consented to this and understand it. And then there's people who understand it from a different perspective and do not consent to their family member receiving it and are very vocal in about their family member not receiving MAiD. So it's very challenging to see how to support both sides, because we do need to support both families in the situation as well as supporting the patient. I think another challenge is being that within acute care, I have a very finite amount of time with the person before they're considered off my roster and no longer even accessible through one content or following up, and how long is an appropriate follow-up time given my scope of practice. So I think those are the biggest challenges that I've seen personally as a social worker.
Thank you. Cheryl, I wonder if there's anything that you can add of things that you've noticed or heard about in your role?
I have not heard of kind of specific challenges that social workers are having. I have certainly heard through our team that patients and families often struggle with the psychosocial piece of this and really are looking for support, and particularly when there are disagreements amongst the family about this option and how to navigate that. So I know that our nurse navigator does a lot of that support over the phone, but that's really where the need for having a social worker on our team emerged, was just, helping her as well, because she's speaking to all of these patients and families and, having that support. So
thank you. And one of the things that came up during the development of these guidelines, and some of the members of that committee are here with us today, thank you so much for joining us, is that sometimes social workers, especially early on where there wasn't much understanding about this new law and the unique role that social workers play or should not play, sometimes social workers are afraid of doing something wrong. So they might err on the side of, I'm not going to provide any counseling because you're not supposed to counsel for MAiD. And that is really more of a misunderstanding of the word counsel, right? Counsel is in advise. You should not advise someone to choose that, but counsel is in provide emotional support to someone, is something that we are there to do. And so one of the goals of our guidelines is to really clarify what can and can't be done more clearly. Now, the issue that both Cheryl and Haley discussed of how to handle things when families disagree with patients on certain issues, that's actually going to be a part of our focus next session. So we will have a chance to delve deeper into it. There is a question here about what is the average timeline between making a referral, being approved, and an individual signing for consent, if that is the appropriate language. Here in Nova Scotia, I guess.
Yeah, I think that's the appropriate language. Being assessed, so yeah, so assessed to meet the eligibility criteria. So that's a hard question to answer, but I can appreciate where it's coming from. So I guess one thing to note is that when we receive a referral, there's a triage process that takes place. And so the highest priority, so we may have patients who are at very high risk of losing capacity, their disease process is further along, and timing wise, it's really important to at least begin the process as soon as possible. So those patients are prioritized. We have other patients who would fall into another category where they would like MAiD as soon as possible, but not expected to lose capacity. And then we have patients who have a goal of MAiD, but in the future. So they're not looking for anything to really start soon. So we try to prioritize based on that triage. We are hoping to develop better indicators around that and be able to measure wait times a little bit better. It varies because, like I said before, we're working with providers who are doing this in addition to their existing roles. So the number of people out there able to support the process really impacts our ability to respond quickly. And you may have noticed in the last month, we actually ended up putting a pause on MAiD referrals at a certain point. And the reason for that was we were just really struggling with assigning assessments to providers and felt it was actually unethical to engage in an assessment, that initial intake assessment, and not be able to reasonably provide MAiD within an expected time frame. And so we did that pause. We have now unpaused, and hoping that with our nurse practitioner added to the team, that's going to hopefully avoid that from ever happening again. But it could range. Honestly, it could be a week, it could be a month. The one area where we are struggling for sure is the group of patients whose death is not reasonably foreseeable. We're having a much harder time assigning those assessments to providers. So again, that's something we're hoping our nurse practitioner would be able to help with, is to at least start the assessment process. And our goal really moving forward is to be able to at least do the first assessment as soon as possible. So at least just to get things going and be able to have that contact with the patient and reassure them about the process and what's going to happen next, because a lot of our providers have said that that first visit actually helps them to, it helps to answer questions, helps them to understand the process a little bit better. So at least being able to do that first assessment as soon as possible, I think is important. And we'll start kind of setting some benchmarks and targets on those things so that we can evaluate our service and make sure that we're resourced to do what people are looking for.
Thank you. And, what's important to remember is how new all of this is. And so building up the resources, the capacity, not knowing what the demand for it will be, that kind of operational logistical planning is certainly challenging as well. We are going to have a chance to talk about social justice implications in our last session, but it does seem like one would be increased funding for resources. Because what we're hearing is that a lot of the providers are, for example, this isn't their primary job, it's something they're doing in addition to everything else, and that can contribute to delays. There is a question here around, are there specific therapy groups or counseling available for family members after the death of their loved one through a medically assisted assistance in death procedure? And Haley, I feel like you mentioned something briefly about that, but I don't know if both of you want to speak to that. It seems like this is an area of growing need.
I think, like you said, it's a very new area of need, because before there was groups for individuals whose family members had died via suicide. And because MAiD has only recently been brought up as an option for procedures is within the last 6 years, I really haven't seen a whole amount that has come up. I did speak briefly to somebody in hospice and was made aware that there was one-on-one supports through their social worker, and that would be probably the most appropriate avenue to go through first. But I haven't received anything that has said like this person or this group of individuals have outwardly started anything. Now, probably Cheryl knows a heck of a lot more than I do, so I'll mute myself on that.
It's certainly a gap, but I think the resource you mentioned is probably what I would have mentioned as well. what we have heard from family members is that they don't necessarily feel like grief groups are the most appropriate for their situation. So they, they would like to see some specific groups or even peer support. So this has come up. We've been involved in some research in the last while where some researchers have been interviewing family members whose loved one died of MAiD and asking them, how did it go? What were the gaps? And I think one of the big gaps that came up is the ability to access grief support that's specific to MAiD, but also seems to be a desire for being able to talk to another. So kind of more that peer support. So being able to be connected to another family who had gone through the process, just to be able to ask questions. And so there's some really interesting ideas, I think, or opportunities for being able to support family members after the fact, or even during the process. So just being able to connect with others. So the other thing that we are working on with, again, through a research project that we're hoping is going to be funded is a MAiD support plan. So being able to develop a specific, almost kind of like a birth plan, but a death plan, and just really being able to help patients and families document and kind of think about all of the different components of MAiD and what they need to plan for, and being able to document their wishes. And so that's something we're hoping we can create as well. I am actually just frantically looking here because Virtual Hospice has recently released some really good modules, grief modules related to MAiD. So I am going to find these now so that I can hopefully paste the link into the chat box. So
thank you. And we'll look at whether we can also include that in our resources for individuals. Also in the chat, I see Family Services of Eastern Nova Scotia offers grief support 6 sessions. So that's great to know as well. And obviously this is a new kind of grief, a unique grief for family members that may look a little different. So for all of us, in perhaps working in private practice or in a clinical setting, being able to understand the uniqueness is something that could be helpful for us as well. 2 other questions have also popped up. One is how many, if any, hospitals in Nova Scotia prohibit medical assistance in dying from happening in their facilities? So maybe we'll start with that. And then there's another question.
So I will answer that briefly. St. Martha's Hospital does not allow MAiD in the hospital. However, we have I'm going to get the word wrong. It's a community center or basically another facility that is right beside it. And so that is where MAiD would take place in that community if it was if someone wanted to die in a hospital setting or in a facility. That's the only one that I know of.
And for a hospital, for a patient that is in that hospital, are they still able to get a referral to speak with someone from the the MAiD assessment team? They're just not able to receive those services in that hospital. Okay.
Yes.
And so
I think one of the great things about the MAiD access and resource team is that you can self-refer as well. So it doesn't require a doctor referring you. Sometimes we do that in the hospital for ease of access here, but it's not necessary. So I think that's a really good point about the access and resource team, is that any person can refer themselves as well.
awesome, thank you. And Cheryl, I see that you just put the virtual hospice resources. So that's virtualhospice.ca.
Yeah, it's very long link, but that should bring you right to where you need to go.
Yeah, it's a great, great resource, and I'm sure there are other resources that may also be helpful. There was a question about other factors that might influence a person in requesting medical assistance in dying, such as income level, education, and race. I don't know if that kind of data has been published, if you've been looking at that.
So we do not collect or report on that data right now. However, part of the new legislation that was introduced is to start collecting that type of data. So Health Canada actually directs what data is required to be collected. And so they are working right now on outlining those data elements, and we are going to have to start reporting those. So not, I think, income level, race for sure. Disability is another one, and I'm trying to think of, there's a whole bunch of new reporting that we're going to be required to do that we didn't have to do before. So I have to go back and refresh that.
Well, and that's, again, this is new, but when we think about potential social justice implications, especially with the expansion of medical assistance in dying to include conditions such as mental health challenges or disability, that brings up a whole host of other ethical and social justice components, which we are not addressing here. They are not in the current component of what is happening in terms of the changes to MAiD, but it is expected to begin 2023, as you saw. So it's important for us to be aware. Haley, I don't know if you were unmuting to respond.
Oh, no.
Okay.
Sorry.
The question was, how can a hospital opt out if they are all owned and governed by Nova Scotia Health?
So this particular hospital has a historical agreement that was signed, and for religious reasons, they do not allow MAiD. And I'm not going to get into the legal issues related to that because that's not my scope.
Good to know, and probably more information is needed. There was a question for clarity. If in the hospital you can self-refer, but at home, do you need a nurse practitioner or doctor, or you can self-refer at any point?
So you can self-refer at any point. It's just sometimes in hospital, what example I was using is that sometimes our doctors will just fill out the referral to make it easier for the patient.
Got it. There was also a comment from personal experience of a friend's partner who went through medical assistance in dying. Yes, the grief is very different. It starts from when the date is set, not from the date of death. So that's one sort of thing that is being shared. And I'm sure there's a lot more that can be shared. One last question, is there going to be more information regarding an individual's capacity to consent versus beyond capacity in the other presentations? So this is not necessarily fully something that I think we're going to be dealing with in the presentations. It's actually a separate topic that the Professional Standards Committee is looking at, is around capacity to consent and what does that look like. So I do want to invite anyone who wants to be on the Professional Standards Committee. Haley is one of the co-chairs. Erin is joining us. She's the other co-chair. And we are just forming this committee, although many subcommittees have been very actively working this summer, including this medical assistance in dying. All right, Haley, it looked like you were getting ready to answer. I don't know if you were.
I was just going to talk briefly about capacity, because capacity, unfortunately, it's changing who can assess it now. Typically, it could only be done by an MD or a psychiatrist. But now there are courses that you can take to be an official capacity assessor within the government. However, within the Nova Scotia Health, as it is right now, the policies dictate who can assess capacity. However, as a social worker, you can lend your part of your assessment or things that you've seen to that assessment. It just can't be bulkily decided on you. So an example being that on my unit, I work primarily with individuals who are seniors and therefore more at risk for developing dementia, and a doctor who sees, a patient for a very finite amount of time because they have many, many patients. We might work together with the nursing staff to look at a person's capacity over time and if it fluctuates and how that fluctuates and stuff. So we'll get into that. There's going to be a whole nother seminar on that as well.
Awesome. So thank you everyone for joining us. Thank you, Cheryl and Haley in particular, for bringing some of your answers and some of the perspective that you have to this. There's great information in the chat as well. And I am really excited to hopefully see all of you and some of your colleagues, if you want to tell them to join us at our next session next Friday, where we will begin to discuss some of the ethical implications, some of the therapeutic skills involved. How do you handle a situation where you have, for example, some of the cases where there's family dissension or disagreement around medical assistance in dying, and what ethical decision-making process should a social worker undergo in considering that. So much more to do. This is, but it's also been really great to have a window into two of our social workers working in this area and having a sense of some of the complexity that they deal with. I kind of want to do that with every single person on this call and all of our members. I feel like there'd be really rich learning if we could see and learn from each other about all of the practice wisdom that is collected. With that, the link to sign up for next week's session is on the Eventbrite. You should be able to see the link to the other two sessions. So one will be next Friday, and then the other one will be on November 17th, I believe. And we will be having actually a lawyer who will be joining us to give us more information. Would a MAiD working group be of use? I think that's a really interesting idea. We're actually looking at communities of practice and developing communities of practice so that people who are interested in a specific area of work could join and meet together and just share. And it sounds like this might be one potential community of practice. With that, Cheryl, Haley, thank you so much. Thank you to all of the people on the working group who helped to develop these standards. And most importantly, thanks to all of you who are interested in learning and ensuring that you are able to provide the best care to all those that we are called to serve. So with that, thank you so much. This video will be available very shortly. So thank you.